we are going to be discussing something very interesting and important this night, which is ethical issues in suicide prevention and management. The main part of the discussion will actually be interactive, but before we get to the ethical issues surrounding suicide prevention and management, I would like to start with a background of what suicide is. As the admin said earlier, suicide is something that you don't have to be a psychiatrist before you come across it, especially now that it's very prevalent in our society and in the world generally. So most of the time, the suicidal patients will even pass through the general practitioners or some other specialists even before getting to the psychiatrist. So it's very important for each and every one of us to be very familiar with what suicide is. So this is the outline that I'll be following as shown on the screen. Introduction, epidemiology, etiology, risk factors, warning signs management, and the rest of it. So for introduction, by simply defining suicide, suicide is just the act of intentionally killing oneself. It's an attempt to solve a problem with impaired problem-solving skills. And it occurs across all races, religion, source of income, social status, educational levels, and the likes. There are some forms of suicide that are not suicide in its real sense, like euthanasia, which is assisted suicide for someone that is having a terminal disease or something like that and wants to kill himself. So in that case, he uses the help of a doctor or a health worker to kill himself. And this is actually legal in some countries, like the countries listed here, Switzerland, Netherlands, and Belgium, but it's not in Nigeria. And then some people have also likened suicide to murder. And that's why in some countries, suicide itself is a crime. And especially in Nigeria, we must all know that in Nigeria, suicide is a crime, and a failed suicide attempt is punishable under the law in Nigeria. Though this is one of the things that the mental health bill that is still on the floor of the Senate, that has gone through the public hearing, is going to correct or wants to correct the fact that suicide should not be a crime, especially because we know that there are a lot of psychological processes that go on behind the scene in a suicidal patient. So that shouldn't be a crime. But then as it stands in Nigeria at the moment, suicide is a crime. And suicide is a spectrum. So when we talk about suicide, we are talking of when the person starts to have thoughts and ideas of killing himself, of hurting himself. And then these thoughts and ideas will now come into reality when the person starts planning. So we now start to have organized plan. The person will either say he wants to use a knife or a gun or hangs himself or things like that. So when the plan, and then after the plan, then the real act itself. So the act itself may not be successful or may not be successful. If it is not successful, that's a suicide attempt. But when it is completed, that is a suicide. And then according to the WHO, which is a definition that is all encompassing, suicide is an act of killing oneself deliberately initiated and performed by the person concerned in the full knowledge or expectation of its fatal outcome. Why this definition is important is that it differentiates suicide from parasuicide or deliberate self-harm. In parasuicide or deliberate self-harm, there is actually no intention of killing oneself, though it can eventually lead to that. In deliberate self-harm, the person is just trying to hurt himself or herself, because it's even usually commoner in females, the deliberate self-harm, just to hurt herself, either for attention or for some other thing, or for some other circumstance. But in suicide, the intent is actually the fatal outcome, to kill himself or herself. And that's one thing that we should differentiate, especially in our society these days, most of what we see from the point of view of a psychiatrist, most of what we see on social media nowadays that being termed suicide attempts could actually just be parasuicide or deliberate self-harm and not necessarily a suicide attempt in itself. Though a parasuicide or a deliberate self-harm may eventually lead to a completed suicide mistakenly. So, for example, a, a young lady, an adolescent girl, just wants to have the attention of a boyfriend or a parent, and then she decides to drink sniper, thinking that and when they see her drink sniper, they'll quickly rush her to the hospital and then they will resuscitate her and all of those things. And unfortunately, they get her to the hospital late, and then she dies before she gets intervention. So that's parasuicide that actually led to a completed suicide, but that was not the intention. The epidemiology, as I've said earlier, it's a global concern. The prevalence and incidence is increasing all over the world, and there have been different reasons that have been proposed for this, which we are going to talk about later. There are about 800,000 suicide committed yearly, and that's one in every 40 seconds, as against 700,000 in 1990. We can see that over the course of 2 decades and more, the prevalence and incidence of suicide has increased markedly. And this is a WHO figure that one in every 40 seconds, someone somewhere is actually committing suicide. And in 2016, 1.4% of all deaths were attributed to suicide. It is the 15th cause of death worldwide and the 10th in the US. And it is the second cause of death among adolescents, as those between 15 to 20. And that is why it is very, very important for us to talk about this, especially for those of us that are becoming parents and our children are growing up and getting close to that age group. This is something that we should look out for, because it is why it is very common among them is that the signs that we usually see for a person that wants to commit suicide are not typical in adolescents. So even the psychological symptoms that we have are usually very atypical. So it is very difficult to suspect that something is going on until the deed has been done. But then we'll talk about this later on in the discussion. So there is bimodal peak, that's between 15 to 30, that's among adolescents and young adults. And then in the very elderly people, that's greater than 70. And then male is more than female. This is actually for completed suicide. And one of the reasons that has been postulated for this is that when males try to commit suicide, they use more fatal means than females. So when males want to commit suicide, they likely use gun or hang themselves, things that are more fatal, more likely to end up successful than females. So when females want to commit suicide, they're either using poison, drinking poisonous objects and the likes that would still take longer time for the suicide to be completed. And usually they get intervention before and they don't eventually get to die. But while in males, they use knife, guns, and more dangerous weapons to attempt suicide. So attempts to complete suicide rates to those that attempt to complete a suicide rate, that's 25 to 1. That means out of 26 attempts, only one will be successful. That's to show us that most of the time people don't get to complete suicide. And that is why most of the time when you hear that someone has completed suicide, there is usually a past history of attempted suicide in that person. And the number one predictor of a future suicide attempt is a previous attempt. So we should take note of this. And this is very important when we are dealing with our patients. So if patients come to us with other medical conditions and there is history of suicide attempts, that patient needs to be referred to a psychiatrist immediately, because the number one predictor of a future suicide attempt is a previous suicide attempt. Nigeria has been ranked to be 72nd out of 183 countries in terms of the number of completed suicide and this country listed the Lithuania, Russia, South Korea, and Belarus rank high among countries with cases of suicide. So these are some of the weapons or means that have been used for suicide. We have pesticides, firearms, hanging, drowning, falling from heights, and in recent times, organophosphate poisoning has been on the rise, especially in Nigeria. So these are just some charts to represent things we have been talking about, and we can see that generally among adolescents and young adults, the prevalence is high, but it is highest among those between 20 to 24 and 25 to 29 years of age. And then this is looking at it from different regions of the world. And it is highest in Europe and Eastern Mediterranean, and in Europe, and then in Southeast Asia and Africa. Why Europe? Because there is a part of Europe, the Scandinavian countries, Eastern Europe, the Eastern European countries, they have a very high rate of suicide in those countries. Norway, Belarus, Sweden, and the likes. And that is what accounts for this high percentage among Europeans. And of course, in Africa, we can explain that because of the high level of poverty, poor education, economic crisis, security crisis, and the likes. It's been said that 90% of those that commit suicide have a background psychiatric illness. And out of these 90%, from various studies, but most studies have even shown that out of that 90% of those 90% actually have a depressive or a mood disorder, and then followed by a drug abuse problem, usually alcohol or cannabis and other substances. And then a few percentage, we have schizophrenia, personality disorders, and other psychiatric disorders. So in essence, majority of those that will be seen to commit suicide have a depressive illness in the background. And that is why, and that's one thing that accounts for why most of the etiologic factors that has been seen in suicide are also seen in depression. So we'll talk more about this slide later on. So some of the etiologic factors, there are some theories that have been propounded by different people. Emil Durkheim is someone that proposed theories both in depression and in suicide. And he categorized people that commit suicide into four. So we have people that commit suicide based on egoistic, some are on altruistic, the others is fatalistic and anomic. So the egoistic, this is when people feel like they don't belong. They feel they feel like they don't have any purpose in that society, and they become desperate. So people that do not have attachment to a community or the society that they live in. So the kind of suicide that they commit was what is termed egoistic. So for example, people that are from the minority community that live among a set of people. So for example, if a black man is living in a white dominated area, maybe in Europe, for example, and then because of the racism and every other thing that comes around living as a minority among people like that, that is what is termed as egoistic. Altruistic is when there's excessive integration and then the person sees himself as someone that should sacrifice for others. So altruism is like saying you want to benefit every other person, even if it has to hurt you. So that's what altruism is. Altruism is a form of defense mechanism that is now postulated to be a basis for suicide in some group of people. Then the next one is anomic. Anomic suicide, as we know, when you say anomy, that's when they say the state of anomy. So for example, what is happening in the country right now, where there's economic crisis, security crisis, everything seems to be upside down. then people get frustrated, and for some reasons, for all you care, a lot of people would have committed suicide during this period and it will not even be reported. So whatever type of suicide is committed around this type of period is what is termed as anomic. When there's a state of anomy, when there's a state of lack of social direction, where there's abrupt change in the society, then fatalistic occurs among people who live in overregulated and unrewarding lives. So this is like maybe when someone has been kidnapped. So when he's in a den of the kidnapper and then he commits suicide in such environment, that's fatalistic. So Edwin Schneidman proposed a theory where he said suicide is caused by a certain kind of psychological pain called psych ache, like headache, psych ache. So psych ache is defined as a general psychological and emotional pain that reaches intolerable intensity. Risk factors operate by increasing psych ache, which predisposes one to suicidality. So now I'll use this opportunity to explain something about suicide, because a lot of times people get confused why a young lady will be heartbroken by a boyfriend, and then on that same day or the following day she commits suicide. And then you begin to wonder that has this girl been thinking of suicide before? So that heartbreak is synonymous to the psych ache Edwin Schneidman is talking about. However, this kind of person must have had some predisposing or risk factors on the background. So there's already a vulnerability to commit suicide. So that event is what the risk factors will now aggravate. So that event will now lead to intolerable intensity that will now eventually lead the person to commit suicide. And that is what happens in most people, even in depression. So there is usually a group of risk factors. So sometimes there's family history of depression, maybe the person is already taking substance, there's a comorbid medical illness or something like that. And then something happens in around the person, in the environment of the person. Maybe the person loses a job or loses someone close to her or him, and then that will not trigger the thoughts of suicide. It's not like it was just that one event that is leading to suicide. There are already some vulnerability factors in the background. So that event is just what will now lead to the intolerable intensity to commit suicide. So David Wood now talks about fluid vulnerability model. He said suicidal episodes are time limited, and risk factors that both trigger a suicidal episode and determine the duration and severity of an episode are fluid. Imminent risk cannot endure beyond periods of heightened arousal. Baseline risk varies from person to person. This is very similar to what Edwin Schneidman is explaining. But then what this is just trying to say is that there could be periods where the person is suicidal, person is thinking about suicide, organizing and planning suicide, but he may never attempt the suicide. Then that episode could go, and then another episode will come again, and at some other episode it will lead to attempt, may not be complete, and these episodes are usually very fluid in that they move in from one episode to another episode, and there are risk factors that will determine when to move into an episode and when each episode will end. So Thomas Joyner wrote a book, Why People Die by Suicide. He identified attracted belongingness and perceived bodysomeness as the forces that produce desire for suicide. He proposed three factors that mark those most at risk of death from suicide: the feeling of being a burden on loved ones, the sense of isolation, and the learned ability to worth oneself. So the fact that people feel like they are a burden on others because of the kind of responses that they get from those people. So from a child that grew up in a very hostile family where the mother and the father, they're always shouting at him or her or abusing him or her. Abusing could be verbal, physical, sexual, whatever it is. And then this child is not feeling like, am I a burden to these people? And why are they reacting to me this way? And then the sense of isolation, growing up or being in an environment where you don't feel loved, or you don't feel like you are with them socially, and then the learned ability to hurt oneself. So a person or an adolescent or a young adult that is used to hurting himself or herself, deliberate self-harm, self-mutilation, has a high risk of ending up to commit suicide. So now the risk factors in psychiatry generally, we like to look at etiology and our management from the biopsychosocial approach. So we are going to be looking at the risk factors from biopsychosocial, environmental, and sociocultural. The biopsychosocial. So now under the biological, the way we group it so that it makes more sense. So we look at it from the biological. So biological, we are looking at it from the genetic point of view. We are looking at it from family history, twin studies, adoption studies. Those are the kind of things we look at when we look at genetic. Because and why this is so in psychiatry is because there are usually no, in fact, it's not there usually, none of our disorders or conditions have a specific cause or a specific etiology. It's usually as a result of a complex interplay of different factors. And these factors are usually biological, psychological, and social. So biological, we are looking at the genetics. Is there family history? Are there chromosomal abnormalities that have been identified? So for example, in suicide, it has been found that people that attempt suicide or that commit suicide usually have low level of serotonin and brain-derived natriuretic factor, and then they also have single nucleotide polymorphism in tryptophan hydroxylase 1 and 2. Tryptophan hydroxylase is the rate-limiting enzyme in the production of or in the synthesis of serotonin. And these two phenomena are also found in people that have depression. The fact that they have low serotonin and they have single nucleotide polymorphism in tryptophan hydroxylase. So that's biological. And then we have also seen that family history of suicide is usually a very strong predictor of suicide in another family member. There's this popular novelist. I'm trying to remember the name. I think it's Ian Hathaway. I can't remember the name. If I get the name before the end of the present, I say among 4 generations in that family, there were 5 recorded completed suicide in the family across 4 generations. And this is one of the examples that is usually brought forward to show that family history of suicide is usually very strong. And I've actually seen at least 2 or 3 cases that way, where the mother or the father died by suicide, and then we are seeing the patient who has attempted suicide too, and not even once, twice, and we now manage and hope that there will be no further attempts. So family history is usually very strong, whether in parents or in siblings or in other first degree relatives or even second degree relatives at times. Then now, psychological, so I've said it earlier, mental disorders are usually present in about 90% of those that commit suicide. The remaining 10% are usually accounted for by things like suicide bombing, people that commit suicide out of pride. When I say pride, so because there are some cultures when some things happen. So for example, a warrior goes to war and then he loses the war, but he was not killed. So rather than going back home, he will rather kill himself. So those kind of things are those that account for the remaining 10% of those that commit suicide. And that is actually on the decrease now because some of these things are usually culturally attached. But the one that is still known is the suicide bombing, especially among the terrorists. And this one has not been shown to be due to any specific mental illness. So mental disorders like mood disorders, as I've explained, anxiety disorders, and other personality disorders. So personality disorders that have been associated with suicide include borderline, antisocial, histrionic personality disorders. So I'm not going to bore with that. Other factors, other risk factors that are associated with suicide is alcohol and other substance use. And this is very common now in our society. And I hope maybe at some point during the programs of the virtual assembly, there will be a program that will be dedicated to talking about alcohol and other substance use disorders. Because it's not just common in the general society, it's also very common among health workers, especially doctors. We are beginning to see a lot of doctors coming down substance use disorder, especially substances that have therapeutic uses too. So when I mean substance, so we have substances like pentazocine, diazepam, and the likes being abused by doctors. So this is something that we need to look at. And then history of hopelessness, impulsive or aggressive tendency, history of trauma, previous history of suicide attempt, as I've mentioned earlier, then comorbid physical illness, especially chronic disorders, have also been shown to be risk factors. So environmental risk factors include job and financial loss, homelessness, relational and social loss, easy access to legal means. And this is one of the reasons why suicide is also said to be high among doctors, because there is access to legal means. There's access to to medications or to injections that can be used to complete suicide. And it is even highest among anesthetists, and that should be of no surprise. Also high among psychiatrists anyway. So local clusters of suicides that have a contagious influence. And this, I'm going to mention something about this. And I think I mentioned it at some point during on the Doctors Assembly page, but I think people do not get what I was saying there. Recently, there has been a lot of suicide reports on the news, on the social media. And one of the things that has been identified to even further increase the incidence of suicide all over the world is the way the suicide are being reported. The report is really too detailed and too vivid. And it has been advocated that the reports of suicide should not be too detailed. They should be conservative, so that you don't give. So for someone that is just at the stage of suicidal thoughts or ideas, when you describe someone that has committed suicide successfully and you describe in so much details the method that was used, how the person killed himself, how he wrote a suicide note, and all of those things, you are beginning to give shape to the idea that this person is having. And it's likely the person will move up the spectrum from just having a thought or an idea to now having an organized plan and then completing the suicide. Next slide. So lack of social support and sense of isolation, stigma associated with help-seeking behavior, barriers to accessing healthcare, especially mental health and substance abuse treatment, certain cultural and religious beliefs. For example, the belief that suicide is a noble resolution of a personal dilemma. And this is related to what I tried to explain earlier. And this last point is what I just finished explaining. Exposure, especially through the media, and influence of others who have died by suicide. So protective factors include strong problem-solving skills, positive self-image, spiritual life through faith. In our own setting, one of the reasons why we don't even have more suicide cases than we presently have is because of the religious beliefs. The two main religions in this part of the world, Islam and Christianity, are clear on the fact that suicide is wrong, that suicide is a sin. So this hold people back a bit, even when they have the thoughts. So when you see patients, passively they have the thoughts, but they will tell you like, and I don't want to do it. So that is actually a protective factor. Then close family relationship, community connectedness, access to treatment, restricted access to means of suicide. These are all protective factors. So these are the warning signs. So when the person is talking about it, when the person is ideating and is talking about it, if there is substance use problem in the person, if there is sign of purposelessness in that person, if there's anxiety, if the person feels trapped, if the person feels hopeless, if the person starts to withdraw from others, or it becomes irritable and angry over little things, or it becomes reckless and then has mood changes. So the acronym for this is the part one. In addition to this, another thing that we should look out for is if the person has been writing things, maybe like suicide notes, notes that appear like the person is planning to leave or the person is planning to go, and we see this person writing such repeatedly or doing some final acts, trying to beg people for forgiveness and the likes. When we see things like this, we should be wary of the fact that this person may be planning to commit suicide soon. So the management. So the question that has been asked is that is there any emergency medicine stronger than suicide? That's debatable. But then suicide is not just a psychiatric emergency, it's both a medical and a psychiatric emergency. And the first thing is to move the person to safety, to resuscitate the person immediately, and then take history and do a suicide risk assessment. When we are doing a suicide risk assessment, there are things we are looking out for. We want to be sure of the person's age. As we have said, it's commoner among adolescents and young adults, and then the very elderly. You want to take note of the sex. You want to take note of the mood, the state of that person. Is the person sad at that moment? Is it depressed at that moment? You want to be sure if this person has had a past psychiatric history before, if he has ever been diagnosed, if he has any comorbid medical illness, if he has an organized plan before committing that suicide, and even if he still has that plan. Because for some people, at the time you are resuscitating or you are trying to save their life, they're actually feeling regret that you didn't allow them to complete the suicide. So that person is actually is at a very high risk of committing suicide again. So the first thing to do is that immediately that person has been resuscitated successfully, that person needs to be admitted into a psychiatric ward. Someone with a suicidal thought or idea should not be discharged on immediately. So you want to examine fully, you want to check if there's any injury or harm that has been done to the body, and then you want to examine the mental state. This one may require the input of a psychiatrist, and then you want to treat appropriately whatever complications that has been, whether the person is going to need suturing, if he was stabbed, if he has to be moved to the theater, if he has to have a gastric lavage or activated charcoal or whatever it is. This is to be a medical emergency at that point. The person will not be in my own ward. But then he has to be treated appropriately. Then after that, the treatment of the psychiatry on the psychiatric ward will now depend on the background psychiatric diagnosis that has been found in the patient. So now the prevention is that you have to restrict access to lethal means. There must be government policy that will support people presenting early to the hospital, that will reduce stigma among those that have psychiatric and psychological illnesses, so as to make it easier for people to seek help. And then, as I've said earlier, the parts of the law that makes suicide a crime needs to be amended. Because what has been said about that part is that a person that is trying to commit suicide in Nigeria, though that part of the law is not usually applied, I've not heard of anybody that went to prison or to jail for attempting suicide. But the implication of that law is that if someone is trying to attempt suicide, the person knows at the back of his mind that, guy, I need to complete this, and this thing has to be successful because you don't want to go to jail if you survive. So the motivation to even make the suicide successful is even more. So now there should be screening in high risk environment and public education, like in jail, school. There should be community volunteers. There should be reduced harmful substance use, faith-based activities, which has been shown to be very protective, access to healthcare, both mental and physical, community support, and then social intervention. So the WHO response, September 10th has been set aside as a World Suicide Day, and the prevention of suicide is everybody's business. There's collaboration of International Association for Suicide Prevention and World Health Organization. They undergo mental health promotion and suicide prevention. The SDG 3.4 talks about reducing mortality with suicide reduction as an indicator. And MHGAP is Mental Health Gap Action Program, is a WHO program to scale up services for mental, neurological, and substance use. And one of the conditions that has been prioritized in that program is depression and suicide. And then in Nigeria, there's something that's a Suicide Research and Prevention Initiative. This was launched in March 2017. It's an initiative of Lagos University Teaching Hospital in Diaraba. And majorly, the aim is for suicide prevention through research, crisis intervention, health education, and early treatment of depression and drug abuse. It's currently spread over 40 health institutions across 28 states in the country. So now, to the meat of the presentation itself. This case is a case of 20-year-old female banker with low mood and suicidal ideation. Although she doesn't live with her family, her parents are located in the same city and are unaware of the severity of her condition. Over the years, she has benefited from both inpatient and outpatient treatment, but she has insisted that she doesn't want her family to know about the nature and severity of her condition. Should the family be informed about the nature of her condition? Discuss the ethical principles that support your decision. So before we answer this, let's just briefly talk about some ethical principles in medicine or medical ethics. So as a form of introduction, ethics is a system of moral principle which defines what is good or bad for individuals and society. So medical ethics is moral principles that we use or guiding principles that we use in our medical practice. It provides tools for thinking about moral issues, affect how we react to situations and interests, no right answer, or there are usually several right answers, as in this case. So now there are 4 fundamental principles: autonomy, beneficence, non-maleficence, and justice. Autonomy basically talks about respect for patients, respect patient self-determination. Patients have the right to accept or reject recommendation for medical care if they have appropriate decision-making capacity. All we need to do is to ascertain that this patient has decision-making capacity. Once we have established that, the patient has the autonomy to choose what type of treatment to have or what type of treatment not to have. And under autonomy is also what we call confidentiality. Confidentiality is one of the principles under autonomy. Confidentiality is what is knowing that the information the patient has given you is limited to that setting, and having to divulge that information to a third party will have to be with the consent of the patient. Then beneficence is doing what is best for the patient. Definition of what is best may be derived from the physician's judgment or the patient's wishes. So going back to autonomy now. So that's why we see that there are usually no right answer, or there are usually several right answers. Because even when you're talking of beneficence, you still have to consider the autonomy of the patient. And then non-maleficence is talking about do no harm. And physicians are fallible. We are equally capable of harming as we are helping our patients. The most important thing is that as we are trying to help the patient, we must do no harm. We must not give any form of treatment that will harm the patient or withhold treatment that would have helped the patient. And then justice is fair allocation of resources. Patients in similar situations should have access to the same care. So justice is talking about equity and not equality. So justice is that patient A came before patient B, so patient A has to be seen before patient B. But then, if patient B has a more serious condition that requires emergency care, and patient A does not require, even though patient A has come before patient B, justice in this situation is actually seeing patient B before patient A. So, next slide. So now, what's the doctor-patient relationship is based on trust, patient interest, and is based on ethical principles, and there's a risk of abuse if relationship is intense and patient is vulnerable. That's why we'll now be talking of boundary crossing and boundary violation. So confidentiality, how does it work? There's no identifiable information about patients that should appear on shared documents or platforms, e.g. social media. So, for example, you had a patient that you feel you want to share the knowledge with people on Twitter, on Facebook. Whatever information you're going to put out there must not contain information that will be traced back to that patient by whatever means. And do not talk about patients in public places where others may overhear. And even if you're talking about it among colleagues, try to avoid using patient's name. And be careful in giving results over the phone. If you have to give results over the phone, let us try as much as possible to cover the patient's name and request patient's permission before releasing information, even to relatives. So gradually we are answering the question that we asked ourselves earlier. Should the information be given to that patient's relative? Now the patient has said she doesn't want them to know. So that's confidentiality. Now you restrict access to folders and electronic documents, and then special care in group or couples therapy. Because in group therapy, some information will have to be shared and all that, but special care should still be taken. So in what conditions can confidentiality be breached? Disclosure of information within doctor-patient relationship to a third party could either be oral or written and may be breached in the following condition: with patient consent, with a court order, if there is a public interest, and to prevent crime. And this may be done oral or written, as earlier said. And we have to be wary of litigation. So now, in the public interest, Paragraph 1 and Paragraph 2 is something that readily comes to mind. I'm sure we can remember that from our undergraduate days. Paragraph 1 simply is talking about duty to warn, and Paragraph 2 is talking about duty to protect. So now, a patient, usually a psychiatric patient, has expressed intent to harm a third party. So, for example, I have patient A, who is my patient, and has expressed intent to harm Mr. B, who is her ex-boyfriend. Because she has told me that information, I have a duty to warn Mr. A that so patient has expressed intent to harm you. That is breaching of confidentiality, but that is supported by the law, and is even supported by the law in Nigeria too. Though Paragraph 1 and Paragraph 2 is a law from what was derived from a case in the US, but then it has been adapted to our law in Nigeria too. So if someone has expressed intent to harm another person, and you know that the patient will still have access to that person, you must warn that person. That was the initial ruling of that case. But after a few years, there was another ruling that came out that even said that the physician must also protect that person So now it's a bit different in the case of suicide because the person that is going to be harmed in this case is still the same person, not a third party this time. So now, so Tarasov may not be applicable in the case of suicide under the law. Tarasov will not be applicable. But let's go on. Code of Medical Ethics in Nigeria, guidelines for breaching confidentiality. This is from the MDCN Code of Ethics. So before you can breach confidentiality, you must seek the patient's consent, whether or not you judge patient can be identified from disclosure. You must de-identify the data of the patient if possible. Keep disclosures to the minimum that is necessary. Balance is needed in underage patient and parents or guardian. This is usually a very dicey situation. An underage patient, a 13-year-old, a 14-year-old, gives you confidential information. And then you are thinking, am I supposed to tell the parent or the guardian? There is really no hard and fast rule about it. There are some of the information that you will have to tell the parent. There are some that you may not need. So there should be a balance. This one is usually at the discretion of the physician, depending on the consequences of keeping or divulging the information. Because at that age, the person is still a minor anyway. So the issue of confidentiality or no confidentiality is not as straightforward as it is in an adult. The duty of doctor at last is employment and patient's death. So the fact that a patient is dead or the fact that you are no longer working where you saw that patient does not mean that you are not still obliged to keep the patient's information confidential and is not precluded from disclosing the truth if accused by patients. So some challenging situations in confidentiality. Seeking information from others. Ensure it is for patient interest before seeking information. Disclosing information to others. Information should be disclosed only with patient consent. Information should be disclosed only with patient consent. But this time, this 26-year-old banker has not given us the consent to disclose this information to our parents or to our relatives. Then assessment on behalf of third party, for example, fitness to work on behalf of an employer. So this one is actually very dicey. An employer has brought some set of workers or some set of prospective workers to you to assess, whether to assess their physical state or their mental state, to be sure that they are fit to work in their company. And then you find some things that makes them unfit to work in that company. But the patient or this prospective worker does not want you to divulge that information to his employer. But you need to divulge the information to the employer because it's the employer that got your services, not the person in question. So the question is, what do you do in that situation? I will leave that for discussion. Then care in the community, patients must be informed that the information could be shared with the other members of the care team. Group therapy, family therapy, and couple therapy. In this situation, it's usually very difficult to keep information confidential because the aim of this therapy is to use whatever experiences they have had as a means for therapy and for recovery. So usually, the issue of confidentiality does not usually come into play when we talk of group therapy, family therapy, and couple therapy, because the aim is to divulge all the information, because it's those information that we are going to now use as a means of treatment or recovery for the individuals involved. So some exceptions to confidentiality. Exceptions in the patient's interest. For example, information needed for emergency life-saving intervention. Exceptions in the public interest. Disclosure of communicable diseases, unfitness to drive, informing third party of potential harm, as I've explained under the Tarasov 1 and Tarasov 2. Exceptions for legal representation. There may be needs to allow legal representative access to certain information in patients' about patient's condition, even without the patient's consent. So now beneficence, this is to produce benefits, to always act in the best interest of the patient, includes being honest to the patient, avoiding unnecessary investigation, individualized care when you talk about resuscitation and lifestyle counseling. So now, coming back to the case at hand, the two major principles that apply to this case are autonomy and beneficence. And under autonomy is confidentiality. So the confidentiality here is that the patient, you know that this patient has a depressive illness and the patient is suicidal. But this patient wants to keep this information to herself. But then this patient lives alone. So the easy way out is to say you are going to admit the patient. But unfortunately, you can't keep the patient in the hospital forever. And they have to discharge this patient home, back to the environment or back to the home that she's living alone. And I must say here that it is actually suicidal to allow a suicidal patient to live alone. Let me come again. It is suicidal to allow a suicidal patient to live alone. It is not allowed. In fact, it's not even an option. So now this patient will likely go back to live alone. If this patient goes back to live alone and commits suicide, and then the parents get to know that she actually attended or she was admitted in your facility and you allowed her to go home to live alone, you could be sued for that. At the same time, if you go ahead to tell the parents, because she needs psychosocial support, she needs people to stay with and support her and give her the moral, emotional, and psychological support that she needs. If you go ahead to tell the parents because you want them to provide all this, she will sue you for breaching confidentiality. So in that case, what do you do? So this question was actually a question from our last part one exam. And the truth is, I don't think anybody, out of everybody that wrote it, I don't think anybody wrote the same thing. And I'm not sure anybody filled that question anyway. So it still goes back to the fact that there's no right answer and there are usually several answers. And in fact, in answering that question, I did not stick my neck out to say this is what I'm going to do. And I'm not still going to stick my neck out this night to say this is what I'm going to do. But at least we understand the circumstances that surround the events and the implication and the consequences of taking one decision over the other. But if I must stick my neck out, I would say I'm going to inform the parents. But before informing the parents, I'm going to involve a lot of people. First, I'm going to involve the forensic psychiatry units in my facility to guide me on how to go about this. And I will also involve the legal team of the hospital. But the most important thing is that this patient needs that psychological support. She cannot live alone. And the only way I can get that, except she's going to provide someone that she thinks is going to live with her. And she's single anyway, she's not in any relationship, the way the question was framed. So the best bet is for me to still have her parents around. But I will involve the legal team and the forensic psychiatric unit in taking this decision. Because another thing we need to know is that patients who are suicidal are at the highest risk of committing suicide just after discharge from the hospital. Because at that point, they are usually out of their depressive state. So they have high energy level. During the severe depressive state, there's low energy, there's reduced energy. So there's little likelihood to commit suicide. Even the cognitive functions are slow at that point. But at the point of discharge, this person is usually out of the depressive state, but does not mean that it's no longer suicidal. So they're usually at the highest risk, and this is actually from different studies. They're usually at the highest risk of committing suicide just after discharge. And that is why you would never ever want to discharge a patient who is suicidal to go back to live alone. And another point, the fact that you see a suicidal patient happy, energetic, laughing, does not mean that the person is no longer suicidal. In fact, it is at that point you should be wary most of the person committing suicide. So I will stop there. I'm sure we all have a lot of things to say about this. We can look at it together and discuss. So I will conclude by saying, when you see a suicidal patient, you ask about it. Don't think that because someone is depressed, you don't want to bring the thoughts of suicide into the person. Don't worry. If the person had no thought of suicide before, if you ask about it, your asking is not going to bring the thoughts of suicide into that person. That we know from study, from research, and from science. What we just worsen is if you describe a suicide vividly to a patient that already has suicidal thoughts. But for someone that does not have suicidal thoughts at all, if you ask about suicidal thoughts, that is not going to put the suicidal thoughts into the patient. So ask about it when you see a depressed patient. Keep them safe when you find someone that is suicidal. Be there with them and listen. Help them connect to support. Help them connect to support, which is why I will want to involve the parents of this patient and follow up and stay connected. Thank you for listening.
Thank you for organizing this beautiful program. I guess this weekend is a weekend of good lectures for me because I've just been receiving them back to back. And I want to thank the facilitator and presenter, Dr. Odunbaku, for a beautiful presentation. It was apt, concise, and it was very short for a psychiatrist. It really shocked me. Thank you very much. My contribution for this topic, I would like to contribute both on the question and the topic generally.
Please go ahead.
Depression is one topic I actually take to heart because I see a lot of these patients, and I feel we tend to underdiagnose depression in our clinics because so many patients come to our clinics with depression, but they just like them because we treat the physical things that they bring. I can tell you that in the adolescent clinic in GOP, UITH, a lot of all these adolescent patients, by the time you interact with them, you will be shocked at the kind of things they will tell you. The amalgamation of this Western education and most of all this social media is creating a very high increase, coupled with drug abuse. The depression increase is actually far rising than we believe it. And somehow, based on the medical education that we've been brought up with, we tend to deal more on the physical presentation and the complaints of the patient rather than the psychological wellness of our patients. The patient is coming with DM. You do your fasting blood sugar, you do your glycated hemoglobin, you give DM drugs. Bye-bye, Baba, bye-bye, Mama. You're not worried about the psychology of that patient coming in and leaving out. I could remember there was a patient that came to our skin clinic with psoriatic skin lesions, a young lady. We were through with the discussion. One of our guys just asked about her psychological well-being, and she entered tears. We assumed, okay, fine. Funny enough, the father even said that that's how she has been behaving for a very long time. So they asked one of my senior colleagues to actually interact with her. And lo and behold, she has actually even attempted suicide once that was not successful because the junior brother came to pick the sniper away. It's down to us to actually, apart from discuss whatever it is the patient is presenting with, discuss their psychological well-being. You'll be shocked at the number of people that are actually battling depression in our society or come in with a smile every day. And one other thing we tend not to do is we assume position of social support. This person, since we discussed with the person, we involve the pastor, we involve the father, we involve the mother. That might not be where the person finds succor. It might not be the place where the person feels relaxed. And it might not be the point of leisure or the point of being free. Doing a brief family cycle or an echo map might shock you to find out who the person trusts the most, who can actually get to the person. You will be shocked that maybe it's one auntie, or maybe one is one colleague, or maybe is one co-worker that actually gets the person, that the person feels very, very attached to, that can actually help you break that cycle. Because the truth is, if you don't break the cycle, you treat whatever it is the patient comes in with, the patient goes back into that society, the cycle will continue, the patient will come back to you with depression, either in a depressive state, or God forbid, you will meet the patient in the morgue. And so it's best to not just analyze our patients, but also analyze the family or social support. During the presentation, Dr. Odunbaku pointed religious beliefs as one of the strong factors that has reduced the rate of depression in our society. Yes, but for me, I think the other thing we have that is strong in our society is social support. It's going to, you won't believe the number of atheists we have amongst us. Most of the children, at least within our environment that I interact with, are in that religious line, either because they were born into it. Most of them is not by choice. So with the little literacy they gain, they start to query a lot of things. It's quite sad when people bring up things against religion on the social media. You'll be shocked at how many people will be throwing that at it, people will be puncturing it and having ideas of their own. Now, forget all these people that are talking, they go to one form of religious gathering or the other. If you feel religion is what you are going to use to change this psychological belief, you will not get that kind of change. So you have to first interact with that patient, find out what is that person's stronghold, find out where you can actually find social support for that person, then you can now move on. Also, you have to interact with that social support to explain the kind of burden you're about to place on them before you go ahead. Now, so I won't waste our time too much. To answer that question, I think Major Odunbaku, along with the beautiful presentation, already answered the question. The only thing I want to chip in, it might not be the parents you will call upon. You might try to interact with that patient to find someone else that you feel the patient sees as a form of social support. Maybe that will be the person you call upon. It's after you've tried interacting to get a form of social support to no avail, and the patient is adamant that should tell no one, that can now involve the legal team, the forensic team, so that at least if ever it becomes a legal lawsuit, it should have been that you've actually dotted every I and you've crossed everything. Thank you very much, Mr. Presenter. Thank you very much, Dr. Odunbaku.
Hello, good evening, DA members. Good evening. My name is Odunbaku. My contribution is that the last speaker raised a very important observation, and that's that we look at the medical aspect alone without looking at the psychic of the patient. And that's why usually what I just do is as soon as we initiate the discussion, sometimes the patient will give you some non-verbal clues that we should ensure we watch out for. And those non-verbal clues are quite important in your overall assessment of the patient. And then as soon as you are almost concluding, it's always very important to look at the ideas, the concerns, and also the expectation of the patient. And to assess the psychological aspect, what I just do straight is I just ask, how is your mood like? And if they've got anything, they would pour everything out for you. And if there is nothing, you see. And by the time you ask those questions, you watch out for those non-verbal clues. And then you will be able to know do I need to dig deeper or not? And do I need to send to the psychiatrist for further evaluation or not? So it's quite important we watch all those things, and so that we can give the holistic care. And I'm not going to answer the question. Then Dr. Odunbaku raised a very important question. When it comes to matters of ethics, there are no right answers, truly, and there are multiple right answers. It is a fact. The only thing we should just try and do is we should stay within the confines of what the medical ethics has dictated for us, and most times you don't go wrong. Thank you.
Okay. Good evening, everyone. Thank you, Dr. Odunbaku, for your presentation. I just want to make some comments based on, I'll look at it from pediatrics perspective. Most of the time, we tend to ignore the fact that children, even when the presenter was talking, he started referencing the least age about 15 years, if I get that right. Even children younger than this age group, we have seen some of them that have come with attempted suicide. So I would suggest that apart from looking at patients when they come into our offices and come with one ailment or the other, we should also look at taking psychological evaluation to schools because of these children in schools. I'll give example of some of the attempted suicide that I've seen in my few years of practice. We had a sickle cell disease patient, I think about 10 or 11-year-old girl that set herself on fire just because her parents did not buy her Christmas clothes. So she said she will punish her parents because they didn't buy her the clothes, and then decided to pour herself petrol and then lighted herself. And of course, she regretted it, but all the same, I think if the psychological evaluation has been taken down to the grassroots, at least for this kind of a girl, to her school, to let her parents also understand the fact that you have a child that has this chronic disease and then needs to be evaluated on a regular basis, this could have been prevented. We also had another adolescent that attempted raping his cousin and was caught in the act. The parents of the cousin just locked up the child in the room. Okay, when day breaks, we'll sort out the issue. And before daybreak, he had already injected sniper and was almost at the point of death before they could realize this. All these children, they are like between the ages of 12, 13, thereabout. So my suggestion is that we should take this suicide prevention down to the schools. Primary school level is not even too small for you to start talking about these children, about the bad side, the complications of suicide, and then evaluate them on a regular basis, because you never can tell what is going on in the heart of these little ones these days. Then also the parents also needs to be sensitive. By the time you are talking to these children about their psychological state in schools, by the time we have all these meetings they have in schools that parents come to, we should also learn to um, include the parents, let them understand the fact that the psychological state of their child needs to be monitored by the parents. It's not just by giving the children everything they want and then drop them in school and zoom off. When they get home, the parents too should be part of their child's life so that they'll be able to identify the warning signs early. And then if you pick it up from this early stage, by the time they get into the adolescent, when the peak risk of suicide becomes when they get to the peak of the risk of suicide, I think we'll be able to minimize this act at that level if we start from the very tender age. Thank you. That's my contribution.
Hello, thank you very much. Thank you, Dr. Odunbaku, for the presentation. Actually, Dr. Abdullah has said most of what I intended saying, actually, with regards to getting to speak with the patients and knowing who they would rather want to be discussed with, rather than assuming it's the parents, and that will go a long way in helping. Because for all we know, the parents might even be one of the reasons why, one of the triggers for which they might want to commit suicide. Another important thing I wanted to talk about is now among we colleagues, you know, uh, the rate of depression is actually going up among medical practitioners as well. We've had colleagues that have committed suicide. So apart from consultation with patients, we should also pay important attention to our colleagues' stress level, how they're coping, and all of that. And I think one other important reason why it may be difficult for many of us to, apart from the medical aspects of patients' presentations, to go into the psychological part is the challenge of the number of patients we do see. Take for example a heart failure clinic where you see over 100 patients. You wouldn't have time to want to explore, the psychological aspect of things. So I think that's one of the challenges for, if in a way we could, just like Dr. Rubenge said, say verbal cues or non-verbal cues, you may want to explore more. Of course, out of 100 patients, maybe one or two will be the one manifesting such. And if there are, leaflets or stuffs that you can just use to tick boxes, just to know, you can do a preliminary assessment, and then if there will be a need for referral, to behavioral scientists, because I know people's orientation as well. Once you mention that you need to say psychiatrist, think it's all about schizophrenia and all of that. Meanwhile, depression is, I don't know the data or statistics, but I think it's on the increase even more than schizophrenia. So it will be very important to always pay attention to that. By and large, it was a wonderful presentation. Thank you for bringing this to the front burner.
Okay, thank you very much. So, I just want to make a few comments based on what has been said so far. I, I have based on the issue of the pediatric age group. Actually, what I meant by from 15 is that is when it becomes more prevalent or marked. Of course, one of the charts that I showed actually also indicated that suicide is also has also been recorded among children between 10 to 14. But from 15 up until 29, that is when it's actually more prevalent. You understand? So, and I agree completely with every other thing that she said, especially as it has to do with sickle cell disease patients. I mentioned in the presentation that those with comorbid physical illness, especially chronic illnesses that has chronic pain conditions like sickle cell. And also, in addition to that, there's also an increasing level of substance use among patients with sickle cell disease, especially what's it called now, pentazocine. And this is something that we all should take note of, especially those of us that are into general practice. I know that the pediatricians and the hematologists and the likes, they have a better way of controlling the pain and all that in such a way that the patient may not get addicted or dependent on these substances. But most of the time, those that are into general practice, private practice, because the aim in that is just to relieve the pain and not necessarily following a particular guideline or treatment modality and the likes. So they just give the pentazocine indiscriminately. And because these patients know that this is what they're using to relieve the pain all the time, they start to use it themselves. And so we get a lot of them having substance use disorder, especially with pentazocine, diazepam, and the likes. So we all should also take note of this. And then for what Dr. Luke Benga said, I think that's actually very, very important. Non-verbal cues from patients. Most of the patients that will come to the GOPD would not come to tell you that they are depressed. So because for depression and for anxiety disorders, there are some somatic symptoms, some physical symptoms that come with it. So it is those physical symptoms that they will bring to the GOPD. But then you have to now look beyond those physical symptoms. And as Dr. Olugbega said, one question that would give it away is just asking how they've been feeling in the past 2 weeks. How has their mood been in the past 2 weeks? From there, you'll be surprised at what you're going to get. So it's a very, very important thing that we need to note as family physicians or specialists in other fields, even in O&G and the likes. Patients will come and complain of internal. I remember there was even a patient that had to clerk for my 500 level exam, and the patient's complaint was that gynae clinic. You can imagine. So you like, and so patients will come to clinic and make complaints about all sort of things. But what is really happening is a psychological disorder. Then to the issue of the support system for patients. Actually, I agree with Dr. Dele Abdullah that in interacting with the patient, you need to understand the circumstance of the patient and where the social support is. In fact, as I said, truly, in some cases, the parents may actually be one of the contributing factors to whatever is going on in terms of the depression and suicide and the likes. So I actually agree with him, and that's a way of looking at answering this question too. That do you want to ask the patient that is there anybody she's comfortable with knowing about this condition and who can provide support for her? That's actually a good way to look at it. And I also a message now from Dr. Oguntade that there is actually a guideline for pain management in sickle cell disease patients. And in fact, that in a center, they don't use pentazocine. And once the pain is not well controlled, pain and palliative will get invited. And I think this is the way, really. And I think this is something that should be advocated more, especially for those in private practice, because it's actually very, very terrible when you have to see sickle cell disease patients with everything that they have to go through. Then you now have to add substance use disorder to it and depression at times. For most times, you have to add depression, substance use disorder, sickle cell. So that's like so many risk factors for suicide already. It's not something that you would want to have in a patient like that. And finally, there's one of my senior colleague here that I would want him to also contribute, maybe after Dr. Abdusalam, Dr. Batomi. So maybe
Okay.
if you have two things to say.
Hello, can you hear me? Yeah, good evening,
Yes.
everyone.
Good evening.
Yeah, Dr. Odunbaku, thanks for the nice presentation. I actually didn't begin with you guys, but I just joined halfway. But I just wanted to ask or make this kind of contribution that, these days people usually link financial status. Like, for example, now in Nigeria, now we know how the economy is and all that. So, is it really relatable to the depression and suicide risk and all that? Then, two, if a patient comes like that and complains, like his own risk factor or his own linking is financial or whatever status. So, how are we to go about it? Yeah, thank you. Thank you. Thank you very much.
Okay, so that question, I think because of the presentation, I answered this that usually there's one single cause to any psychiatric disorder, especially depression or suicide. You can't say it's just one thing that has led to it. It's usually an interplay, a complex interplay of so many factors. And so I mentioned this example specifically that in a situation of economic crisis as we have now, or maybe in financial loss or loss of a loved one and the likes, it is not just that is leading to the depression. There will be other factors that would have been in the background. So the person is already vulnerable. So and that's why it's not everybody that has a loss or that has undergone a loss that will come down with depression. Because some people already have the vulnerability factor to go into depression. So when that thing now happens, it's just like a trigger. You understand? Where they get to that point of intensity that now leads them to having depression or having suicidal thoughts. So, for example, the person could have had the family history of depression. The person could have had the genetic predisposition to have depression. The person could have been having substance use disorder before then, or having a comorbid medical illness. A lot of other things could be anything. But what the baseline is that is an complex interplay of different factors. But then, and that is why the clocking in psychiatry is usually very long compared to other specialty, because what we do is that we are trying to look at all these factors and looking at how we can solve all the problems. And that is why our management is usually in the biopsychosocial model. So we are looking at managing this patient on all these three fronts. So the biological treatment is when we give the antidepressants and antipsychotics or whatever medication the person requires. But then we also have to now look at some psychological treatments that we can give based on the contextual factors we have found in the person. We also look at some social treatments that we can give based on the contextual factors we have found in the person. So, for example, if this person doesn't have a job, how are we going to rehabilitate this person occupationally? If this person have issues with family, how can we do a family therapy to resolve the family issues? Things like that. So it depends on the factor that we have found or the factors that we have found that will determine the specific treatment modality. But what is usually common in all the treatment modality is the biological treatment. Most of the time, a patient that is suicidal would have the depression in a severity that will require medication. Someone with mild depression is not likely to be suicidal. So, and it's not because it's only in mild depression that we would say that maybe there's no need for medication and we can just make do with just psychological treatment. But for someone that is suicidal, that person will likely and is depressed, that person will likely need to be on medication, most especially antidepressants. Then the other forms of treatment will now be individualized based on the factors we have found in that person. So if you have found some cognitive errors that is driving the depression, so the person could need treatment modality like CBT, cognitive behavioral therapy, could need dialectical behavioral therapy, depending on anything we have found. So that's the way to go about this.
Thank you very much. It's also nice to be here. I want to say well done to Dr. Odunbaku because it was a very wonderful presentation. Like he really broke it down and he spoke our mind collectively as a psychiatrist because he was explicit. I just want to say that we should never be too scared to ask our patients about suicidal thoughts or suicidal ideation, as the case may be, especially even if the patient is depressed or has attempted it. It's not a sin because the sin is even if you don't ask. So you must ask and re-ask so that you'll be able to pick it and you can manage it as soon as possible before the patient kills his or herself. So generally speaking, really Dr. Dumbaku has broken it down and I wouldn't want to take much of our time. I just want to say well done to him and I want to encourage everybody to please, what we have learned, we should try to practicalize it in our various centers so that we can reduce the prevalence and incidence of suicide in the environment. Thank you very much.